Hypoglycemic agent is not 100% technically correct. Can anyone tell me why? What has nothing to do with bioavailability? What do you mean by hypoglycemic agent? The drug which decrease glucose level, right? So in this way, if you take it in a general way, these are the drugs which will always decrease sugar level. Even if it is taken by a non-diabetic person also, then also it will decrease blood sugar, right? But not all the drugs used as an oral medicines which are used for the treatment of diabetes, they don't do the same. Okay. So those are called as euglycemic agent. Means if your blood sugar level is high, it will bring back to almost normal level. But if your glucose level is normal, that is not going to decrease your blood sugar level. So technically the term should be, what it should be called as oral. Can anyone guess? This is used for the treatment of diabetes. Huh? Yes. Oral, nowadays it is called as oral anti-diabetic agent. Now the question is that अभी मैंने यहाँ पे oral hypoglycemic agent क्यों लिखा? Because जो सारे books तुम्हारे पास है सब में oral hypoglycemic agent ही है, ठीक है? And some examiners may follow this point. Okay. So if you are asked about this entire group, initially use oral anti-diabetic agent. Okay, clear? If they make some face or something, then you use this word, oral hypoglycemic agent. Okay? I have to be with your competency things. So coming to the classification, so orally this group of drugs are most commonly used. One is sulfonylureas. Okay? Forget the first drug, tolbutamide. We don't use this drug nowadays because of severe hepatotoxicity and renotoxicity. The other drugs are used very widely, glibenclamide, glimepiride, gliclazide. Okay. Then comes meglitinides. This is also a drug which causes increased secretion of insulin. These all three groups, sulfonylureas, meglitinide, meglitinide, and DPP-4 inhibitors. Can anyone name the full form DPP-4? So these all groups of drugs, they increase the secretion of insulin. So one is our sulfonylureas, then comes meglitinide, that is repaglinide. Netaglinide we don't use commonly nowadays. Then comes your DPP-4 inhibitors, all gliptins. The suffix is, क्या है suffix? सब लोग बोलो, otherwise याद नहीं रहेगा तुम लोगों को. Gliptin, ठीक. अब आते हैं हम लोग, another one, GLP-1. So GLP-1, this is an endogenous compound which occurs when we take oral food. जब हम लोग खाना खाते हैं तब gastric mucosa, then your liver cells and your intestines, GLP-1 is secreted, which stimulates the pancreas to secrete insulin. Okay. GLP-1 is glucose-like peptide 1. Okay. Another one is that GIP, glycogen inhibitory peptide. It has also the same thing. I am coming to this later. So we have GLP-1 receptor agonist. Commonly nowadays in India, three are available: exenatide, liraglutide, and semaglutide. Among them, exenatide and liraglutide, they are given only as parenteral form, that is subcutaneous. But semaglutide subcutaneous भी दे सकते, उसका oral formulation भी available है. Okay. Only difference is that in case of semaglutide, the subcutaneous dose is once in a week, and oral it is once daily. Okay. Now these are the group of drugs which reduce the insulin resistance. अब हम लोग क्या बोले थे, टाइप 2 में क्या होता है? टाइप 2 में इंसुलिन रेजिस्टेंस होता है, मतलब इंसुलिन निकल रहा है पैंक्रियास से, बट बॉडी का रेस्पॉन्स कम. तो दिस ग्रुप ऑफ ड्रग्स does the same. Metformin, and this is the drug which we give always to any type 2 patient, type 2 diabetic patient. फर्स्ट लाइन थेरेपी हमेशा याद रखो, कभी भी अगर कोई टाइप 2 डायबिटिक का पेशेंट आए तुम्हारे पास, always start with metformin. First optimize the dose of metformin, then you go to adding up of some other drugs or insulin. ये basic protocol. Then other drugs, alpha-glucosidase inhibitor. In short mechanism बोल देता हूँ. What is alpha-glucosidase? It causes breakdown of the complex polysaccharides. Okay, so as a result क्या होता है, अगर inhibit करेगा, if the alpha glucosidase is not working, then the complex polysaccharide will remain as it is. तो स्टमक से पॉलीसैकेराइड एब्जॉर्ब होता है क्या? नहीं होता है. So it decreases the glucose absorption from the gut. Yeah, number one. Number one, SGLT2. सब लोगों को पता होना चाहिए. What is SGLT2? Sodium glucose co-transport. This is the receptor which is responsible कि हम लोग ORS के साथ ग्लूकोज क्यों देते हैं. This is not for nutrition. This is just to enhance the sodium absorption. Okay. So SGLT2 inhibitors that also decrease the absorption of glucose. Then D2 receptor antagonist bromocriptine, ये आजकल हम लोग यूज़ नहीं करते because of the numerous side effects. Then एक enzyme और एक है amylin. Okay, amylin means which breaks up the saccharides by the amylase. So it decreases the activation of amylin, which is responsible for the breakdown of the carbohydrates. फिर तुम्हारा dual GLP-1 GIP receptor antagonist, ये सारे नए ड्रग्स हैं, ठीक है. देन आगे तुम्हारा अदर एजेंट्स लाइक हाइड्रोक्सीक्लोरोक्विन. कहाँ पे पढ़े थे हम लोग हाइड्रोक्सीक्लोरोक्विन? 20 दिन के बाद प्री यूनिवर्सिटी है. मलेरिया पे हाइड्रोक्सीक्लोरोक्विन का यूज़ है, हाइड्रोक्सीक्लोरोक्विन का यूज़ है. कहाँ पढ़े थे हम लोग, याद करो. रियूमेटॉइड आर्थराइटिस भूल गए. Rheumatoid arthritis. Presently, this is the drug of choice now, apart from DMARDs. The first group of medicines which include otherwise known as insulin secretagogues. क्या नाम है? Insulin secretagogues. GOGUES. Why the name so? Because this group of drug, they increase the secretion of insulin. They stimulate the insulin release from the body. But for this group of drug to work on, at least, remember, this is an important MCQ, at least 30% of the pancreatic beta cell need to be active. How much? At least 30% of the pancreatic beta cell need to be active. Otherwise, ये group का कोई काम नहीं. Otherwise, if you stimulate also to the maximal level, body won't be able to reach that functional level of insulin. Okay, so that time हम लोगों को दूसरा कुछ देना पड़ेगा. Okay, so mechanism is that body पे जब अगर कैल्शियम या इंट्रासेलुलर कैल्शियम अगर जब बढ़ जाएगा तो क्या होगा? What will happen then? This will result into exocytosis of vesicles, right? Insulin also stored in vesicles. So the function of this ATP-sensitive potassium channel, this sense the sugar level, yes? Oh, chale. Okay, you may leave who have programs. So this ATP-sensitive potassium channel, they work like sensors. When they realize that the glucose level is increasing, ठीक है, तब ये क्या करेगा? तब ये करेगा कि it will stimulate and it will result into increased calcium influx in our body by calcium channels. So there is an intracellular increase in the calcium channels that will cause depolarization, and as a result it will cause exocytosis. Now by inhibiting this channel, okay, so what we are doing here, we are causing partial depolarization. So as a result, there is increase in the potassium channel by phospholipase IP3-DAG pathway, and it will result into release of insulin. So it will result into increase in the insulin channel. So here what happens, normally what it is doing, ये receptor, it's causing depolarization, it's stimulating the depolarization rate. So और भी अगर 10 यूनिट निकलना था, वहाँ से 20 यूनिट इंसुलिन निकलेगा. That's why it is known as insulin secretagogues. Now another group is Meglitinides, Rapaglinide, Netaglinide, ठीक है. ये भी सेम ही फंक्शन करेगा. If you give the same image, एक ही बात है. But only the binding site is differs. ये होता है यहाँ पे, ये होता है यहाँ पे. It's another site compared to the insulin sulfonylurea binding site. First generation is tolbutamide, and all the drugs with G, they are called as second generation. Now tolbutamide हम लोग यूज़ क्यों नहीं करते आजकल? हेपाटो एंड रेनोटॉक्सिसिटी. अच्छा क्या समझे? Okay. So they decrease in the blood glucose in type 2 diabetes mellitus. Type 1 पे क्यों नहीं होगा? इंसुलिन तो रिलीज कर ही रहा है. Type 1 पे क्यों नहीं होगा? Yes. In them, less than 30% of the beta cell is active. So this group of drug is not useful in that case. Remember one thing, till 30% of the beta cell is active, our body is euglycemic. If it is lesser than that, तब हमारा शुगर लेवल हाई होता रहेगा धीरे धीरे. Clear? The 90% protein bound, so the drugs which are highly protein bound, plasma protein bound, they will cause some reactions. Example? Name some drugs which are highly protein bound. This is important drug interaction. Come on, आएगा ऐसे questions. पूछेंगे लोग. Is metabolized in liver, drug interaction with enzyme inducers and inhibitors, ये सारे हैं, देख लेना. Then excreted in urine. Some are in metabolized, some are in unchanged form. सबसे shorter duration है इसका gliclazide, but सबसे potent यही है. Okay, so which has an advantage of using this drug in elder patients? And now the question is that why elder patients? कुछ चीज़ें होते हैं, जैसे in case of elder patients, our diet is compromised, right? Their digestion, their absorption of food, it become compromised. ठीक है, number one. Number two, most of them are suffering from either renal problem or hepatic problem or some other issues. ठीक है, तो उनका metabolism, drug toxicity, how to process the food, that hampers. ठीक है, अब short duration होने से क्या होता है? The hypoglycemic effect which is seen in the elderly patients, it becomes less. तो suppose अगर by chance hypoglycemia हो भी गया ना, तो हम लोग ठीक ठाक मैनेज कर सकते हैं इसको. तो लॉन्ग टर्म कॉम्प्लिकेशन नहीं रहेगा. अ पर्सन हु इज कॉन्सिस्टेंटली गेटिंग अ हाइपोग्लाइसेमिक एपिसोड फॉर अराउंड 7 to 8 hours, उनको मैनेज करना बहुत टफ है कॉम्पेयर टू किसी को अगर सपोज हाफ एन आवर, 1 घंटा या 2 घंटे का एपिसोड है, उसको मैनेज करना ईजी होता है. द ब्रेन डैमेज इज लेस. Whenever there is some hypoglycemic episode, some part of your brain will be damaged. ये मान के चलो. और एक बार अगर CNS के न्यूरॉन डैमेज हो गया, क्या वो रिकवरी करेगा? Neurons are the only cell in the body which cannot regenerate. बाकी सब कुछ ना कुछ हील कर देंगे. न्यूरॉन्स का एक बार हमारे पास अभी जितना न्यूरॉन है उतना ही रहेगा, राइट? बेसिक फिजियोलॉजी. एंड सबसे लंबा ड्यूरेशन है इसका ग्लिबेनक्लामाइड. THF is 8 to 12 hours and the duration of action is around almost 24 hours. You can see the hypoglycemic episode. It's a hypoglycemic effect. साइड इफेक्ट मोस्ट कॉमन, अगर सल्फोनाइलुरेट का साइड इफेक्ट पूछे, फर्स्टली ऑलवेज से दैट हाइपोग्लाइसेमिया. डोंट से नोज़िया वोमिटिंग, इसका नहीं होता है. हाइपोग्लाइसेमिया, ठीक है, दिस इज द फर्स्ट आंसर. ऑलवेज स्टार्ट फ्रॉम दिस. साइड इफेक्ट ऑफ सल्फोनाइलुरिया इज हाइपोग्लाइसेमिया. Then other thing, dilutional hyponatremia, cholestatic jaundice, disulfiram-like reaction. If somebody is allergic to this group of drug, they will have hypersensitivity. ठीक है. Then weight gain, hypersensitivity reactions. Then reduced iron uptake by thyroid. So any person who is suffering from thyroid disorders like carcinoma thyroid, hyperthyroidism, in them the problem may arise. We need to have more focusing. In fact, हम लोग इसको बहुत कॉशियसली यूज़ करेंगे इन दोज ग्रुप ऑफ पेशेंट्स. कॉन्ट्राइंडिकेशन, हाइपरसेंसिटिविटी, प्रेगनेंसी, immediately following acute coronary disease, type 1 diabetes and diabetic ketoacidosis. In diabetic ketoacidosis, we have to use insulin because in that the insulin secretion process is completely shut down. तुम इसको किसी तरह से भी तुम इसको स्टिमुलेट नहीं कर सकते. ठीक है. Then Meglitinides, only one drug we use, Hypoglycemic. But the problem is that its HbA1c lowering capacity is less, only 0.5 to 1%. ये हम लोगों के लिए desired नहीं है, because usually in type 2 diabetes, HbA1c level rises beyond 8.59 like that. तो हम लोग को और भी कम करना है. What is our target? HbA1c? No, in case of type 2, it's not 6%. It's less than 7%. 6% also तो बहुत अच्छा है, but 7% लाना ही बहुत मुश्किल है type 2. Okay. So if we targeting less than 6%, it will definitely induce hypoglycemia, which we don't want in those patients. अगर less than 7% पे लाते हो तो eventually धीरे धीरे करके ये 6% के नीचे आ ही जाएगा. If the person is controlling and maintaining the lifestyle properly. Metformin, first choice in type 2 diabetes. Now the factor is that it has multiple effects. Not only in diabetes, it reduces body weight. So in case of obese diabetes, which is very common, in them also this can be used. A gynecological use भी है. Anyone guess? PCOS. ठीक है. PCOS, this has become the first line drug actually, apart from medroxyprogesterone. Very important plus point is that it does not cause hypoglycemia, even in non-diabetic persons. तो ये risk है नहीं. That's why it is becoming the first choice of drug. And also this group directly targeting कौन सा? Is directly targeting the mechanism for which type 2 diabetes occurs. That is insulin resistance. Okay. That it improves also the lipid profile. Because diabetic dyslipidemia is very common. Because एक ही receptor applicable है, PPAR. Peroxisome proliferator receptor alpha and gamma. They both are hampered in diabetes. Okay, so diabetic patient mostly they suffer from concurrent dyslipidemia. ये बहुत important है. And also then it also reduces macrovascular complication of diabetes. What are the macrovascular complications? Any idea? Diabetes has two important late complications. One is microvascular complications, one is macrovascular complications. Micro means you have a diabetic foot, you have retinopathy, you have nephropathy, right? And you may have diabetic neuropathy. These all are microvascular complications. What are macrovascular? Coronary artery disease, renal failure, then CVA, okay, arthritis, not arthritis, artery, inflammation of the arteries. Arthritis must be confused. Okay. So mechanism is that it stimulate the AMP kinase receptor. So this AMP kinase, till now it has been postulated that it suppresses the hepatic gluconeogenesis and simultaneous glucose release. Then by this it increases peripheral glucose uptake, it decreases intestinal absorption of glucose. Then it interferes with mitochondrial respiratory chain and promotes peripheral glucose utilization through anaerobic glycolysis. ये सारे process glucose produce करेंगे from other things, and as a result it will try to increase the glucose level in the blood. ठीक है. Now all these process they will be stopped by this AMP kinase receptor. ठीक है. Problem is that it increase blood lactate. तो इनिशियली ये बिगोनाइट जो ग्रुप था हमारे पास, तो उस पर 2 ड्रग्स थे पहले जब हम लोग MBBS कर रहे थे. One is Metformin, which is presently now considered to be the safest drug actually. Another one is Fenformin, PHENFORMIN. Maybe पूछेंगे नहीं, but just for your knowledge. So Fenformin has a very high percentage of causing lactic acid acidosis, which itself is a medical emergency. इसलिए Fenformin has been obsolete and has been discontinued from the market. तो presently इस ग्रुप में से सिर्फ Metformin अवेलेबल है, बाकी ड्रग अवेलेबल है नहीं. ठीक है. Then apart from this, as this hampers the absorption, so it will cause vitamin B12 deficiency, resulting into megaloblastic anemia. Then comes other GI side effect. इसमें तुम nausea vomiting बोल सकते हो, metallic taste, anorexia, diarrhea. So these things can happen. And in case of sustained preparation, what is sustained preparation? Suppose we have given some drug which is readily absorbed from the stomach. ठीक है. तो ब्लड का प्लाज्मा लेवल का क्या होगा? How it will go on? It will go spike and again down, right? To prevent that, we have modulated the drug formulation in such a way Like it was suddenly absorbed now, maybe by creating a layer, maybe by absorbing it into lots of pores. Okay? So this is known as sustained channel, sustained preparation. धीरे starting from the stomach to the jejunum, it will get absorbed slowly. So that will maintain a proper plasma level. Okay. So if this kind of preparation has been given to any patient, it has been seen that the totally पूरा tablet ही निकल गया stool के साथ. Okay, so that's the problem, but ये ज़्यादा problematic है नहीं. Just blood sugar थोड़ा high हो सकता है, because at least half of the metformin that will go and absorbed. So this is not considered as a serious side effects. तो उसमें से हम लोग क्या कर सकते हैं? अगर ऐसा पेशेंट हिस्ट्री देता है तो सर टैबलेट तो निकल गया पीछे से. मेट्रोमिन आया भी नहीं. हमेशा क्यों पेशेंट को पोक करना? इसको इंजेक्शन देना बहुत पसंद है. क्या करेंगे हम लोग? सिंपल सोच. अबे सस्टेन प्रिपरेशन नहीं देंगे, विल गिव द कॉन्वेंशनल प्रिपरेशंस. सिंपल सोचो, ज़्यादा मत जाओ. Contraindication is hypotension, heart failure, chronic hypoxic lung disease, alcoholics, renal and hepatic disease require dose adjustments. Like if the GFR is less than 50, then the dose should be half. If the GFR is less than 25, the dose should be 1/3 to 1/4. Okay? This is the dose adjustment. And in case of alcoholics, it will further cause lactic acidosis, because those alcoholics are actually prone to lactic acidosis. So this drug will stimulate that process. Use first line drug in type 2 and PCOS. Simple though use. Non-hypoglycemic सबसे बड़ा advantage है, because this is the advantage of most of the preparations. ठीक है, sulfonylurea बोलो, insulin बोलो, other कुछ चीज़ें बोलो, they will reduce the sugar level even in normal individuals. Metformin वो काम नहीं करता है. तो this is a very important advantage of this, and promotes weight loss. Weight loss एक बहुत important reason है कि patient insulin resistant है. Okay, so it promotes weight loss. It prevents complications, other complications, particularly cardiovascular complications and neurological complications. Then no acceleration of the beta cell exhaustion or failure in type 2. ये एक late stage complication है कि टाइप 2 पेशेंट में इनिशियली बीटा सेल काम करता है, ठीक है, बट इवेंचुअली आफ्टर लॉन्ग टर्म ऑफ डायबिटिक पीरियड धीरे धीरे बीटा सेल भी फेल करना शुरू करता है. तो मेटफॉर्मिन स्लोज दैट प्रोसेस. इसके एडवांटेज ये है कि पेशेंट का इंसुलिन रिक्वायरमेंट बहुत लेट होता है, ठीक है. देन इट कैन बी कॉम्बाइंड विद अदर OHA और इंसुलिन, ठीक है. इनक्रेटिन्स. सो इंसुलिन रिलीज कब ज़्यादा होगा? जब हम लोग शुगर खाएंगे या शुगर को इंजेक्ट करेंगे. शुगर इंसुलिन सिक्रेशन कब बढ़ेगा? ओरली लेने के बाद या इंजेक्शन के बाद? ऑलवेज आफ्टर व्हेन वी गिव इंसुलिन, after we give oral glucose, then only insulin secretion will be high. That's why the name of the test is oral GTT, oral glucose tolerance test. IV होता है, ठीक है. This happens because of incretins. Okay, so incretins are GIP and GLP-1. ठीक है. So this is otherwise known as gut hormones. So GLP-1, GIP, VIP, पैंक्रियोजाइमिन, कोलेस्टोकाइनिन, अदरवाइज इसको हम लोग CCK-PZ बोलते हैं. CCK-PZ, व्हाट दे डू, दे ऑल CCK-PZ का मेन फंक्शन क्या है? टू स्टिमुलेट द सिक्रेशन ऑफ द वेरियस गट हार्मोन्स, राइट. इसमें से GLP भी है. सो इट रिलीजेस इंसुलिन फ्रॉम द पैंक्रियाटिक बीटा सेल्स at high glucose concentration. It induces insulin release and it preserves beta cell function and its सर्वाइवल. बट GLP-1 का एक माइनस पॉइंट है, ये ओरली हम लोग नहीं दे सकते, बिकॉज दिस इज वाई, दिस इज ए पेप्टाइड, नाम पे ही पेप्टाइड है. एक्सेप्ट प्रेजेंट प्रिपरेशन, वन एनालॉग इज देयर, semaglutide, दैट कैन बी गिवन ओरल. ओके, दिस इज This is inhibited by DPP4. फुल फॉर्म बोलो, पूछा था मैंने. Dipeptidyl peptidase 4. Okay, this immediately degrades incretins, GLP सारे, ठीक है, particularly GLP-1 and the analogs usually what we give. Okay, so mostly when we are considering the use of GLP-1 analogs, either we select such which is resistant to DPP4 or we give DPP4 inhibitors. नाम याद है? बहुत सारा नाम दिया था मैंने. What is the suffix? हाँ? ग्लिप्टिन. ओके, कुछ नाम बोल सकते हो? याद है? बेंच पे नहीं, पेपर पे लिखो. तुम यहाँ पे लिखोगे, बाकी फिर कोई लिखेगा. 6-7 बैच के बाद पूरा ब्लू हो जाएगा पूरा बेंच. ऐसा चलता है क्या? ओके, सफिक्स क्या था? ग्लिप्टिन. तो ग्लिप्टिन के आगे कुछ बोलना. हाँ, सेमाग्लिप्टिन, सेमाग्लूटेड है, सेमाग्लिप्टिन, सीटाग्लिप्टिन. अच्छा, हाँ, सीता से, अच्छा, अल्फा है ना. अल्फा से सीता का नाम आजकल बहुत लोगों को याद हो रहा है. नहीं, चलो कोई नहीं. इफ यू गेट मी. और सीधा हो गया. हाँ, लीनाग्लिप्टिन. ओके, व्हाट एल्स? ओके, देन हाँ, तो ये को लीना हो गया. लीना जी आ गए. विल्डाग्लिप्टिन. ओके, फाइन, ठीक है. ओके, ये बहुत ही डिबेटेबल कैरेक्टर है. दैट्स द वैल्यू. गुड. ओके, so we'll be coming to that later on. So this is the entire mechanism. This GLP-1, this will stimulate the insulin receptors. So as a result, by various action, insulin will be released. ठीक है. This is damaged. This GLP-1 is damaged by DPP4. So it results into inactive peptides. So what we do, we add up GLP-1 analogs and we add up DPP4 inhibitors, which will cause that breakdown is inhibited. So proper function is maintained for a longer time. ठीक है. Exenatide, liraglutide, ठीक है. Okay. Semaglutide का plus point है कि that it can be given orally, number one. But one important problem is that you can't give it in case of any thyroid disorders or renal failures. Okay. Because that will cause more stimulation to the cancer cells and the carcinoma that will be, क्या बोलते हैं उसको, enhanced. तो पूरा यहाँ पे, ठीक है, just check that you can read. There's nothing to say actually. यही है. Pioglitazone, rasaglitazone we don't use nowadays because of cardiotoxicity. ठीक है. So ये ड्रग के बारे में ज़्यादा just पढ़ लेना. But clinically I don't think that you guys is going to use it ever. Problem, yeah, this is important. Usually diabetic treatment starts with one drug, then you optimize it. Eventually after some day that optimization also will be go. Then हम लोग एक दूसरा drug use करते हैं. ठीक है. Then again we optimize it. That also will be gone after some period. ठीक है. उसके बाद हम लोग 3 drug therapy use करते हैं. So when we use 3 drug therapy, then these groups comes into work. And the most commonly used drug presently nowadays is Voglibose. Acarbose, Meglitol, Voglibose. This is the 3 groups of drug. Okay. How it works? It works by reversibly inhibiting alpha-glucosidase. So glucose digestion and absorption of polysaccharides is inhibited. तो खाने के बाद स्टोमक से जो ग्लूकोज जाना चाहिए था वो जाएगा कम. बट एज ए रिजल्ट वन इम्पॉर्टेंट साइड इफेक्ट हैपन्स. क्या हो सकता है? अगर खाने में अगर तुम्हारा स्टूल पे अगर ज़्यादा कार्बोहाइड्रेट होगा विच इज़ गोइंग टू द इंटेस्टाइन, व्हाट विल हैपन? इंटेस्टाइन में कौन रहता है? इंटेस्टाइन में कौन रहता है? हाँ हाँ, तो इससे इतना कन्फ्यूजन होने का क्या बात है? तो बैक्टीरिया को अगर ज़्यादा शुगर मिलेगा तो क्या होगा? What it will produce? If you expose bacteria to glucose or sugar, what it will produce? Sorry? Galactose. Galactose क्यों करेगा? चावल से दूध बनता है क्या होगा? हाँ, ग्रोथ होगा. And what will be the production? Lots of gas and ethanol and carbon dioxide. So what will it will cause? Flatulence. That is the most important and uncomfortable side effect. So as a result of this, हम लोग क्या करते हैं? We start with the minimal possible dose. Like अगर हम लोग Voglibose मान के चलते हैं, तो we take Voglibose starting from 0.2 milligram. That also not once. At least 3 divided doses. Okay? Because blood पे sugar maintain करने के बाकी ड्रग तो हमारे पास है. We never use alpha-glucosidase inhibitor alone. That will give more discomfort. Okay. We need sugar. We need sugar to be absorbed, but that absorption should need to be controlled. And the level of sugar in the blood, that also need to be controlled. वो अकेला ये group of drugs से होगा नहीं. It will just decrease the absorption. So as a result, the episode of hypoglycemia will be more. So always this group of drug is used as a third combination. First भी नहीं, second भी नहीं, only third combination. अगर हम लोग use करते हैं तो, clear? Bromocriptine हम लोग use नहीं करते. SGLT2 inhibitors, all gliflozin, dapagliflozin, canagliflozin, empagliflozin. These are the 3 drugs which are commonly used. Among them, dapagliflozin has an important cardioprotective property. Okay, so in case of heart failure also, dapagliflozin is very much useful. Side effect, genitourinary infection. Q? This is the question. Why? अगर SGLT2 रिसेप्टर इनहिबिट होगा तो डाइटरी कार्बोहाइड्रेट के साथ क्या होने वाला है? And SGLT2 in case of kidney or nephron, what it is going to be happen? ग्लोमेरुलस पे ग्लूकोज के साथ क्या होता है? Any idea? ग्लोमेरुलस पे ग्लूकोज के साथ क्या होता है? ग्लूकोज छोटा मॉलिक्यूल है या बड़ा मॉलिक्यूल है? हाँ, बहुत छोटा है. 6 carbon is nothing. 6 carbon is nothing. So glucose is very small molecule. So entire glucose is going to be filtrated in the nephron. वहाँ से ये reabsorb होगा. समझे? Nephron से ये reabsorb होगा. So that reabsorption is inhibited by SGLT2 inhibitors. So in urine there is lots of sugar. And जो मैंने भी बोला, bacteria exposed. So there is a high chance of UTI, provided the person is not taking enough amount of water and not going to urinate several times. Number 1. Number 2, if the patient is dehydrated. So genitourinary infection and also breast cancer and bladder cancer, these are rare side effects, but most commonly genitourinary infection is very important. So to prevent that, we have to advise the patient to take ample amount of water. Okay, and don't prevent the micturition habit. ठीक है? Then tirzepatide, नया आया ये group of drug. So this is a novel drug which reduces GLP1 and GIP both. Okay, so it is administered as a once weekly subcutaneous injection, regulating blood sugar and promotes significant weight loss by slowing the digestion and suppressing appetite. Side effect profile ज़्यादा कुछ clear है नहीं अभी तक हमारे पास, so it will be getting slowly. Nausea, vomiting, diarrhea, constipation, abdominal pain, bloating sensation like that. ठीक है? In case of thyroid, T-cell tumors, pancreatitis, it should not be used, and also in type 1 diabetes. Secretagogues. So this is a drug which is approved by DCGI in 2020. 2018 आई थिंक, भूल गया, याद नहीं, देख लेना, ठीक है. So it has an extra plus point that apart from PPAR alpha, that is your rosiglitazone and pioglitazone, ठीक है, it also prevents PPAR gamma. Okay, so PPAR gamma is responsible for your dyslipidemia. ठीक है, so diabetic patients who are also suffering from dyslipidemia, in them saroglitazone is very important. Simple adverse effect: rarely abdominal pain, fever and dizziness, and safety in patients with renal and hepatic disease, plus in pregnancy, it's not yet known because just it has been newly introduced. So in these patients, the drug is very cautiously we should use it. Then imeglinin ज़्यादा कुछ है नहीं, but like your metformin, it also inhibits your mitochondrial metabolism of sugar, ठीक है. So that gluconeogenesis and other processes which produces glucose from other molecules, it is prevented. Now, what is the status of OH in India? दो टाइप का डायबिटीज है, टाइप 1, टाइप 2, ठीक है. Now, ये शुरू करने से पहले बोलता हूँ, any doubt about any drugs? बस टाइम भी खत्म हो रहा है. Do you have any doubt about any drugs in this regard? क्या हुआ? डायबिटीज बहुत इंपॉर्टेंट ड्रग है, एक लॉन्ग क्वेश्चन कंफर्म है, ठीक है. सो रीड इट वेरी केयरफुली. सो व्हाट इज द स्टेटस ऑफ OHA? तो इन केस ऑफ टाइप 1, practically OHA has no effect. Only it is useful in type 2 mainly, ठीक है. That also start metformin always at the time of diagnosis of type 2 DM. अगर पेशेंट का शुगर लेवल वहाँ तक है कि जस्ट डाइटरी कंट्रोल, एक्सरसाइज एंड अदर बिहेवियरल चेंजेस से तुम लोग को नहीं लगता है कि ये डायबिटीज़ कंट्रोल होगा, ठीक है. इफ़ यू थिंक दैट द पेशेंट नीड मेडिकेशन, ऑलवेज स्टार्ट विथ मेटफॉर्मिन एट द डोज ऑफ 500 मिलीग्राम बिफोर फूड, मे बी वंस डेली और ट्वाइस डेली. यूजुअली ट्वाइस डेली से हम लोग शुरू करते हैं, ठीक है. You optimize it to up to 1.5 to 2 gram, depends on the patient's condition and other things like kidney problem, liver problem, etc. ठीक है. Then second line of drug is sulfonylureas, provided the contraindications are absent. क्या था contraindication? What are the contraindications of sulfonylureas? Yes, failure, pregnancy, hypersensitivity. Okay, if the patient is taking any concurrent medications which hampering the plasma half life. अभी तक नहीं बोले कौन सा ड्रग है plasma half life. Okay, एक simple example मान लो, warfarin, which is the most plasma protein bound drug. 99% of warfarin bounds to plasma protein. थोड़ा सा भी निकल गया ना plasma protein से extra, that will cause bleeding. So those things need to be considered. अगर sulfonylureas use नहीं हो रहा है, then you add upon DPP-4 inhibitors, ठीक है. This is the second line of drug option. Then most effective in patients with the age of more than 40 years, because after the age of 40 years only we usually diagnose type 2. Okay, but nowadays few cases are coming out that type 2 patient, their age of onset is around 20 to 25. So this is known as early onset type 2 diabetes. Okay. तो obese बहुत ही important है metformin. Then duration of disease less than 5 years. Fasting less than 200. Confuse मत हो, fasting 200 के ऊपर भी जाते हैं. And in certain cases you will see that fasting glucose is more than the postprandial blood glucose. ये क्या बोल सकता है? Fasting is more than postprandial blood glucose. सॉरी, डीके नहीं, पेशेंट कोमाटोज नहीं है, पेशेंट होश में. सपोज योर फास्टिंग पोस्टप्रांडियल ब्लड ग्लूकोज इज 146, फास्टिंग इज 180. हो सकता है. Two things: if the patient is on sulfonylureas or on alpha-glucosidase inhibitor, number one. Number two, if the pancreatic beta cell is insensitive to baseline glucose insulin secretion. Fasting क्या है? फास्टिंग रात पे हम जब खाना नहीं खाते, जब हम लोग सोए होते हैं, तब 1 यूनिट पर आवर करके इंसुलिन निकलता रहता है, विच इज़ कंट्रोलिंग आवर बेसलाइन लेवल. ठीक है. एंड व्हाट इज पोस्टप्रांडियल? आफ्टर ईटिंग, when the insulin secretion is stimulated, right? When the insulin is stimulated, then this is known as postprandial blood glucose. A beta cell stimulated होता है on the GLP-1 only or the incretins only. GLP-1 बोलना गलत है, incretin बोलना सही है. तो only the incretins. But that baseline means when the person is not eating anything, and when the beta cell is not stimulated by any chemical or endogenous factor, तब जो सिचुएशन बनता है तब होता है फास्टिंग. वो काम बीटा सेल नहीं कर पाता. These are rare cases, but this has happened. I have also got a few patients like that. But initially I was also shocked. ऐसे कैसे हो सकता है? Then when I came across some literature, then it came into these factors. मिलेगा, बहुत पेशेंट मिलेगा. This is the approach. If you ask me to make a question, I'll definitely will ask that, how will approach a patient of type 2 diabetes? So if such question comes, अगर मैं question बनाता हूँ तब तो definitely आएगा. But bad luckily on till your batch, I'm not eligible to make question paper. मेरा 3 साल होना बाकी as an AP. ठीक है. So if such question comes, just give this flowchart. It's very easy. One is न्यू पेशेंट ऑफ डायबिटीज़, आइदर टाइप 1 होगा, टाइप 2 होगा. ठीक है. टाइप 1 होने से डाइट कंट्रोल करो, बिहेवियरल कंट्रोल करो, इंसुलिन दे दो, इवेंचुअली इट विल कंट्रोल ओनली. टाइप 2 होने से देन यू हैव टू थिंक अ लिटिल बिट. क्या सोचोगे? एक हो गया डाइट, एक्सरसाइज, मेटफॉर्मिन. देन आइदर इट मे बी कंट्रोल्ड और इट मे बी अनकंट्रोल्ड. यही तो 2 ऑप्शन होगा ना, आइदर कंट्रोल होगा या अनकंट्रोल होगा. कंट्रोल होगा तो कंटिन्यू दिस ट्रीटमेंट टिल अनकंट्रोल सिचुएशन कम्स आउट. अगर uncontrolled होगा, then we have to consider some factors like whether the patient's body weight is okay, it is more or less or normal. ठीक है. Whether other complications are present like pregnancy, infection, surgery. So if there is no other complication, patient is well nourished, then you give metformin, then 1 sulfonylurea / Meglitinide / DPP-4 / Alpha-Glucosidase inhibitor. इन 4 ऑप्शन में से एक ऐड कर सकते हो. इफ कॉम्प्लिकेशंस प्रेजेंट लाइक इफ प्रेगनेंसी इज देयर, यू हैव टू ऐड अप इंसुलिन. बस तब हम लोग को फास्टर कंट्रोल चाहिए. देन यू हैव टू ऐड अप इंसुलिन. देन हाई चांस दैट इट विल बी कंट्रोल्ड, और इफ इट इज नॉट कंट्रोल्ड देन वी हैव टू कंसिडर सम अदर थिंग्स लाइक कैंसर, फाइब्रोसिस, pancreatic stones. Okay, so these things need to be considered. And sometimes you may have to use at later stage of the disease metformin plus 2 more drugs. And what is the third drug always? Which group of drug is the third drug? Is alpha-glucosidase inhibitor is always the third drug. Okay.